everyone. And we will move to the next debate. It's on multifocal IOL implantation versus monofocal IOL. And I would like to invite Dr. Saliya Pathirana, Senior Consultant Ophthalmologist in Golden Key Eye Hospital, and Dr. Salvin, Consultant Eye Surgeon, to come to the stage. And I'd like to invite Dr. Praveen Dayasena to he thinks that multifocal IOL is a better option in patients to speak. And also against that, Dr. Aravinda will speak on monofocal IOLs. Over to you, Praveen.
Yeah, so good evening, ladies and gentlemen. Welcome to the debate. So I'm going to propose that the multifocal IOL in selected eyes is going to be better than a monofocal IOL. So I think my opposition is Dr. Aravinda. He will be talking a lot about the history of the IOL and how it came to be and how it's the main practice. So my defense here is to defend the multifocal in a selected patient. Shall I start? Yeah. So there are no financial disclosures. First of all, when you say multifocal IOL, there are three things that will come into your mind. One is, you're never going to get all three levels of good vision. The other thing is, there are going to be halos and there are going to be starbursts. So how can I satisfy my customer, who is a patient? So currently, thinking about the future of multifocal IOLs, there are a range of IOLs available. So it is more or less because we sometimes don't know what the available IOLs are and the complications of this. So if we knew what the IOL is needed for this patient, we could tailor-made and may put a lens that is relevant for that patient who is in front of me. So this is the evidence that is comparing 25 researchers out of 1,025 patients with multifocal versus monofocal IOL. To compare what were the complications, what was the patient satisfaction. So we will never be able to compare the subjective experience of a patient unless you put a monofocal in one eye and a multifocal in the other eye. So these are all looks into the comparative patients where they suggest about your multifocal IOL and can I know my time, please? Yeah, thanks. Monofocal IOL and your multifocal IOL. So in these studies, most of them give that there is better outcome in visual and satisfactory outcomes with the patient, but in selected patients there had been side effects. So if there are side effects in your patient after putting a multifocal IOL, I think we have to do a reflective practice whether the patient needed a multifocal IOL in the first place. So it is not the fault of the multifocal IOL. It is because we put that lens in a patient that needed a monofocal or in a difficult patient. So just a little bit on multifocal IOL. So after optics, we know diffractive posterior edge of the lens can have three points in the retina for distance, intermediate and near vision. So this was the earlier type of the multifocal where there were diffractive posterior edge which will split the light ray that comes to you and put it into three spaces in your retina. So these are their trade names are there, but I have no financial disclosures. So there are pros and cons on all the lenses that were there. So the resto was there for a long time. It had two focal points, distant and near, which is 14 inches. So in that patient, they had a compromise of mid-range vision. So after that, the Alcon PanOptics was a good option because it had all three ranges with good focality and the patients were satisfied. Also in Technis, there is synergy with stronger near vision because we are telling the patient that we are going to make them spectacle free, so they should have the near vision well. So this is the high end of the newer type of multifocal, which is called the extended depth of focus, where they do not split it into three, but elongate the focal area. So with that, they have tried to get away with the blurred intermediate segment. So those are the two, VVT and Technis Symphony are the more available lenses in your patients. So when a patient comes to you and asks, I want to be spectacle free, you do not tell that is not available. You have to explain to the patient, because now we are in 2024. I think India has sent a spaceship to Mars. So the patient needs to know that this type of lenses are available, even though it's not in the government sector, because they might opt to go for it. But in the same tone, I would like to say only about less than 10 or 5% of us may go ahead with multifocal IOLs. I have never put a multifocal IOL, so this is not my expert opinion. This is from literature search and academic, American Academy and PubMed. So those are the experts who have operated on many, and they will have their expert opinion on it. So this is a flow chart if you want to choose the multifocal to your patient. So if a patient asks 1001 questions about how it's going to be, better not to put the IOL, because after that you will have to live with that patient for the rest of your life and his life. So keep in mind, summary to summarize, find the ideal candidate for your lens, patient personality, hobbies, value determination, reading point, refractive error, and ocular comorbidities. Very, very important. The value determination is an important point, because even in abroad, multifocal IOLs are coming out of the pocket. So then the patient will require very, very good outcomes at the end. So if you think that this type of patient, suggest a moderate myope who already had good near vision, don't go ahead and put the IOL, so that you will have bad outcomes. So I would like to talk to Aravinda. Multifocal දාලා නැත්නම් දාලා බලන්න ආසිතේ. Thank you.
Praveen, strong emotional speak. Thank you. Okay. So the next speaker, I would like to invite Dr. Aravinda.
Okay, good afternoon, everyone. So I'll be neutral about his comments. I'll go on with defending my monofocal IOL. So first, I would like to talk little about the monofocal IOL history. Yes, as you said, it was invented in 1949, and it has a history of 75 years. So multifocal IOLs, it was invented in 1980, and it has a history about 45 years. And it has developed a long way, and it is still widely used, because technologically it has been really advanced. And with the development of other multifocal IOLs, even we are using this IOL widely. Why? Because visual outcome is good and its technology is good now. And still it is considered as the standard IOL. So I have some facts. We are talking about multifocal IOLs only 5%. This is worldwide statistics. The monofocal IOLs, on almost 95% patients are going with monofocal IOLs, because they are desired to get it. And no studies done in Sri Lanka, unfortunately. And what I can ask is, on your expertise, are you happy with your patients with monofocal or multifocal? I think monofocal patients are much happier than the multifocal patients, because multifocal patients, they are getting more problems with their post-op outcome. Okay, so, and monofocal IOL also, if you have used in a good way, like deciding the target refraction and the monovision, we can get good results, like what we are getting only in the multifocal IOL is the relieving with spectacles. Okay, so these are some advantages of monofocal IOL. So it is low cost. For a country like us, the multifocal IOL is about 10 times costly for the patient. And for us, it's good, like a country like us. And multifocal IOL, if you have used for one eye, the other eye, definitely the patient has to undergo with multifocal IOL. So 20 times higher cost. And it is widely available, very advantage. And better clarity and better contrast, because multifocal IOLs, these are my research, what I am using for the evidence. So it has better contrast and better clarity with monofocal IOL. So certain professions, they can't go with multifocal IOLs. So artists, photographers, they need a clear vision. So they need that monofocal IOL. So post-operatively, there are more problems with halos and contrast issues, glare with multifocal IOLs. But there's good quality vision with monofocal IOL. So there is some research evidence. And you need very high demand of surgical expertise for multifocal IOL, but not in monofocal IOL. Even so, in our practice, all the trainees are doing with monofocal IOLs. If you have selected multifocal IOL, no, you need expertise surgical hands. And you can't get any complications. You should well center the IOL, and also capsular axis should be perfect. And multifocal IOLs out when you are having complications. So 3-piece IOL in sulcus, tucking IOL, scleral fixation, AC IOL, all are monofocal, no multifocal. And they have less refractive surprises, obvious. And multifocal IOL, they need adaptation time, and also maybe it's a longer duration, so it's difficult for the patient. Monofocal IOLs, they don't need any adaptation time. Once you have implanted, next day onwards, they have a good adapted vision. And one special thing, when you get the PCO, it's very difficult to do a capsulotomy in multifocal IOLs. Because of the diffractive surfaces, it's very difficult to focus the 4 beams. And the clarity of the vision goes. So it's out. Why multifocal IOLs should be not good? Because only advantage is spectacle free, but at high cost, and it needs a perfect surgery. And also, there are more chances to get the patient disappointed with their halos, contrast problems, and it's difficult to address. So they have actually done a research and invented a model. This is a mobile model. They have given, because of this problem, this second picture, before doing the surgery, they are giving the chance to the patient to experience the outcome of vision and problems. So why the monofocals we have to go with monofocal IOLs? Newer monofocal IOLs, they have a quality with enhanced depth focus. And also, monovision is an option, as you know, and you need to choose the correct demand, where the patient needs the distance vision or the near vision. And also, we can make them spectacle free if you have decided the correct demand. So I'm thinking, why not monofocal IOL rather than going for multifocal IOLs? So Praveen, you can consider again. Thank you very much.
Thank you, Aravind. And we will move to the panelists. So first, Patirana sir, I think you have done a lot of multifocals. ආස හිතෙනවද sir දැන් මම?
ඔව් දාලා බලන්න කිව්වනේ මම දාලා බලලා තියෙනවා ගොඩක්. Right. It's like this. You see, there are certain contraindications for multifocals, true. But if you consider all that and select patients, and they're extremely happy. And I have to say now, almost over 60 patients, not a single patient has come back complaining to me about much of halos or any of these things, because the trifocals especially reduces the halos and all these problems. Of course, that's why I said you have to select the patient. If he's a photographer, or he's a person who drives in the night a lot, or any other comorbidities like other eye problems, so you have to avoid all that. But once you select proper patients, and their happiness is very much more than a monofocal lens. So in fact, I mean, I'll tell you my experience now. A few weeks ago, I implanted a multifocal lens to a person who is about 44 years old, and he was so happy that he immediately came back and told me, please do the surgery in my other eye, and I did it yesterday. Then another Maldivian patient a few weeks ago, I operated both eyes, and she was so happy. I mean, this neuroadaptation thing may be true, but patients following the morning can see the 6/6 and N5, most of the patients, and they are so happy. And the Maldivian patient, both eyes 6/6 N5, she has immediately gone and told a friend who has had one eye monofocal lens in India. Now she was coming yesterday and she was having a discussion for 1 hour how to get a multifocal lens to the other eye. So the second speaker said that you have to speak a long time, have a bigger conversation for multifocal lens. True, but it's worth sometimes. Have a good conversation, good communication. I mean, some of these Maldivian patients are very intelligent. She was, in fact, I told her, look, I'm going to participate in a panel about this lens. So she said, can I come for the panel? Because she has studied so much about the lens on internet. She was asking 101 questions I had to answer, but I patiently answered all the questions. So like that, you have to find your patients. But if the number one problem in this country is actually, what he said is the cost. Cost is number one. But I think if you exclude all these problems, and if the patient can afford multifocal, you have to give the multifocal to them, because that gives very good results. And then as the second speaker said, there is no problem with the PCO. I have had some patients with PCO resto lenses, which I have put 20 years ago and 15 years ago. My history is so bad, much far away than you. Before you were born also, I have been putting restos. So those resto patients are doing still so well. I mean, there are patients who are coming after 20 years still having distance and near. And once in a way patient has PCO, there is no problem of doing a capsulotomy. Only thing is the multifocal lenses, they might need a capsulotomy a little earlier than in a monofocal. But other than that, there are no problems. So, only thing you have to remember is that, as he said, that the distance vision, whatever it is, the clarity is slightly less in the multifocals. But most of the people who got multifocal, they don't know about the clarity of the vision in the other person. So they are happy with their distance and near. So definitely, if the photographer who has so many jobs, of course you have to avoid. Of course, I have to tell you once, accidentally, long ago, about 20 years ago, a patient, at that time I never asked occupation from each and every patient. And I implanted the multifocal lens. He was so happy, he wanted to get the other eye. And later he came and told me he's a pilot. And remember that always ask the occupation before you think about the multifocal lenses. But he could see so clearly, but the pilots are not supposed to get multifocal lenses. So that day he had gone and found out that he is not supposed to get it, and there was an issue. Then I also got worried. But I gave a letter saying that there is no problem, his vision good. Look, the problem is in the night, in the cockpit, when they look at cities with multiple lights, it's a problem for them, it seems. But that pilot never had a problem. He got the job back. So anyway, like, these are my experiences. Anything else?
If you put a patient with a one eye monofocal, do you consider multifocal on the other eye? What?
Actually, resto lens I have done it. Some patients who are insisting on the second eye multifocal with the restos, I have implanted resto lens in the second eye and had no problem. They can very nicely read with that eye and see the distance, and I think the brain get adapted to it. Still, I have not done it for the trifocals, but now this particular multivision patient is going to put me in trouble. She's insisting that she wants a multifocal lens in the eye because her friend can see so well.
Have you done it, Salvin sir? Monofocal, one eye, multifocal?
Well, I don't do. I have seen patients, but they are not very happy because the one eye, when you put monofocal, anyway, the monofocal, the eye with the monofocal is more clear. Contrast sensitivity is better compared to the multifocals. So they are not happy. Very difficult to make them happy. So better avoid that, number one. If you give me a little more time, yeah, considering your Maldivian, that particular Maldivian patient, but I think he has studied well about the lenses, but not with the eye surgeon, about the eye surgeons. Give me 1 minute. Right, okay, good. That's indirect way of promoting, eye surgeon, being an intelligent person, you probably would have studied about the eye surgeons also. That's why she went to you. But anyway, when you take the multifocal, very important take-home message, which I have taken, is pre-op counseling is very important. You have to tell, right? And always you under-promise, as even in other cataract surgeries, don't say 100%. You put a bit, you may need to sometimes wear the glasses. But if the patient is even for that ready, that patient next day will be very happy, right? So don't promise 100% because you can't guarantee. And the next things, just like you are under promising, doing the counseling very well, do a perfect job. You cannot go, next day you can't have corneal edema, you cannot have methyl cellulose under any viscoelastic under the lens. So those things have to be very clear. Precise surgery is very important because those patients are the ones will be get a very good first impression, the first vision next day. Even after the vision is slowly, gradually goes down, the patient will not be happy. As he said, the first day vision is very important. The other way is not very good now. In fact, I had a patient, we were talking about it with, I mentioned to Chanak also a few minutes back. One patient came from all the way from overseas to get the lenses done on the same day, but unfortunately, due to miscommunications, lenses for the panoptics were not arranged. But Chanak was good enough to provide me the lenses on the holiday, resto lenses. The patient was not very happy next day. But now, gradually, after sometimes his vision is 6:6, the fine letters, he can see it very happy. But still, that the first day vision was not very happy. You know, this is not the lens that he was expected. It takes some time to get adapted. Right? So therefore, the first impression, like for us, the first impression important, the first day vision also important. That one more thing, always tell the patient, if you want to be happy, this is the exact word that I used to tell the patient, if you want to go for multifocal, you have to do the both eyes. The first day when you do one eye, you will not be happy until you do the both eyes. You will be happy only when the both eyes are done. So otherwise what happens, the patient is goes with one eye and wait 1 or 2 weeks. During that period, patient is not happy. So when you tell more before the surgery that you have to do both eyes, patient is ready for that and then will be happy. And one more thing, that if you look at the reasons for only about 5 to 10% of the cataract surgeries are done with multifocal worldwide. The reason is, one is of course money. The second thing is eye surgeons are also a bit scared because it's a hassle for us. You know, when the monofocal, always you can put a lens and make the patient happy next day, and patient also willing to accept. But if the surgeons are willing to put and select the patient properly, put the lens, do a good job, the patient and the doctor both will be very happy, as he said, and your practice also will go, you will be a very popular surgeon if you do like that. So I like to do multifocal as many as possible, but unfortunately it is limited not by my canvassing, but because of the money as elsewhere in the world. Thank you.
Thank you very much. Good lessons from experts, and never promise anything, under promise.